My name is Randy D'Amico. I'm a neurosurgeon at Lenox Hill, director of neurosurgery out at Wyckoff Heights Medical Center. And I'm here with John Bookbar, who's my senior partner here at Lenox Hill, skull-based neurosurgeon, endoscopic neurosurgeon. And we have some special guests today. Joining us, we have Vikas Mehta from Montefiore, who's a head and neck surgeon, I believe, right, ENT, and who just recently published on the experience of cancer patients dealing with COVID. We have Fabio Iwamoto, who's a neuro-oncologist from Columbia, who I know very well from my time training out there. And we should have Mary Welch joining us in a little while as well, another neuro-oncologist from Columbia. And, you know, what we're doing here is the same thing we've been doing every week, which is providing really a patient-centered, patient-oriented discussion about, you know, neuro-oncology, patients dealing with brain and spinal cord tumors as we kind of recover now from this pandemic that's been affecting all of us. So first of all, thanks to everyone for joining in and coming along for the ride. Vikas, you want to start, just tell us a little bit about your experience at Montefiore and what you guys have dealt with kind of as you went through the pandemic and now that you're coming out of it.
Sure, yeah, I want to thank you for having me on and for inviting me. It's an honor to be here. Basically, you know, just like all the other New York hospital systems, you know, ours was getting overrun pretty early on. And one of the things we noticed, an alarming trend, was that a lot of our cancer patients were succumbing to the disease. And, you know, I'd been working for the last year and a half, 2 years on building a cancer database that's allowing us to identify our patients in real time and track how they're doing and this and that. And so, you know, with the hospital had built out a database tracking the COVID patients at the same time. So what we were able to do was just kind of cross-register those and pull out all the patients who had been identified with cancer who were also testing positive for COVID. And then with a group of, you know, dedicated people in medical oncology and radiation oncology, you know, we sort of fast-tracked pulling out and identifying what was happening with the patients. And, you know, of course, we, you know, sort of confirmed what we were seeing anecdotally, which was that, you know, a lot of the patients weren't doing well. And we wanted to, you know, sort of make sure that was real. And we, you know, cross-referenced it, you know, compared it to people who didn't have cancer and people, you know, to age-matched cohorts across New York City. And unfortunately, we saw a much higher rate of people succumbing to COVID who had cancer. Most specifically, the ones that were at highest risk were kind of the ones that you would think about, considering the kind of the way that COVID works. Those with lung cancer were at very high risk. And those who have hematologic malignancies, so things like leukemia, lymphoma, right? Anything that affects the immune system. And then some of the other ones, like more aggressive malignancies like pancreas, colorectal, GYN, a lot of those patients weren't doing that well. So that's, you know, I mean, you know, and we wanted to get that message out there because, you know, New York City, obviously being very hard hit early on in the pandemic, ahead of a lot of the other states, it sort of helped get the message out to, you know, other states. You know, some of the other interesting.
Yeah, absolutely. And you guys got.
Go ahead, please.
Well, I was saying you guys got a lot of coverage from that as well, right? You were saying that it got picked up on a lot of news stations.
Right. I mean, the main reason we wanted it, you know, the findings themselves are more confirmatory than anything else. But, you know, one of the things, some of the interesting things that we saw out of there was that a lot of the people that were getting it had interacted with the healthcare system before we knew that there was a pandemic, you know, how widespread it really was in New York City. And it gave us, you know, what it showed was that, you know, if you don't cocoon the patients and protect these patients very early on, you know, a lot of them can pick it up in healthcare settings, and that's really, you know, can be dangerous for them. So, you know, kind of really pushing or helping people understand the need to be very proactive when it comes to cancer patients and protecting them.
Yeah, well, I mean, we're going to talk about this the whole 30 minutes probably, but there's a lot of very interesting points you just brought up. Before we get going, though, I just wanted to touch base with Dr. Iwamoto. Dr. Iwamoto, how are things going at Columbia? How's your experience been? And I think the importance here is that, you know, this is a show dedicated to cancers of the brain and spinal cord, and that's your specialty. So tell us kind of how you've seen it in your experience so far.
Yes, so, you know,
yeah.
Can you hear? Yeah.
Yeah,
So
can.
very early on, of course, as many hospitals in the New York area, you know, the surgeries for brain, spinal tumors that were not absolutely an emergency were delayed. In the initial few weeks, it was extremely hard to almost impossible to get a patient approved for surgery. So I did have a few patients in whose surgery was delayed, but eventually they were able to get the appropriate surgery, and I don't think it affected their overall care. However, of course, that was very stressful for everyone, especially for the patients and their families. Also, very early on, we transitioned to do most of the neuro-oncological care, which is what I do, by telemedicine. And that has, you know, worked, I would say, well, probably better than I expected. Of course, for visits that you are only checking on the patient and there are likely oral chemotherapy, is much easier to do this telemedicine. But there are, of course, patients who are on either clinical trials or IV medications that end up needing to come to a facility or an outpatient facility to get their treatment. So, and that continued. ASCO, the American Society of Clinical Oncology, very early put that all patients should try to get chemotherapy infusions at home. And in fact, we tried to do that, but it has been quite challenging because it's completely new for insurance companies. And of course, these drugs are also very expensive. And there was not a very good mechanism to do that in a timely way. I mean, at the end, over the several weeks, in fact, I was only able to do one patient to get Avastin at home, but it took my staff several hours to get that done. So I wish there were, you know, especially for the biological drugs that may not require a lot of, you know, pre-medication or monitoring. It would be nice if they could get at home as they can get at home many other medications, IV, but we'll see how this evolves.
Absolutely. Well, with regards to, you know, your study, Vikas, how many neurosurgical cases were included in? I think you had 219 patients, right? Do you remember?
Yeah, something like, a little over 200. There were very few. I think there were less than 10 neurosurgical patients, like patients with, you know, those patients, along with the people who had low-risk malignancies like breast and prostate, their mortality rate was pretty similar to someone without cancer. But some of these, you know, so in that setting, you know, it's a little bit more hopeful, or, you know, I mean, the outcomes were better in those patients. But for the ones who had the, you know, the higher risk types of cancer, you know, the lung mortality rate was something like 55%. And
and I think, you know, that reflects kind of the pathology you're dealing with, right? This is an upper respiratory infection with someone with decreased lung function, and so you definitely have a higher risk. Also, lung epithelium is what's injured primarily, right, in the COVID infection. And so, Dr. Iwamoto, have you seen a lot of neurosurgical patients dealing with the disease, or have you seen, you know, a kind of a differential prognosis in patients with brain tumors, glioblastomas, you know, versus metastases that are doing differently with the disease versus the regular population?
Yeah, I didn't have many patients with COVID. In fact, I had only 2 patients. We have a registry of all the patients, and among myself and my colleagues, we haven't seen many COVID cases in glioma patients, which has been good. I had 2 patients, both with glioblastomas, and both were very, one was completely oligosymptomatic. She had a sore throat for half a day and was tested positive and fully recovered. The other patient had fever and some myalgias, but no major respiratory symptoms. So this one was admitted to a local hospital in New Jersey, but released in a few days and fully recovered as well. I mean,
now, this is super.
Yeah. None of
well,
them
I think this is really. Go ahead, Fabio. Sorry.
Yeah, none of them were in very immunosuppressive regimens, so that may be also the issue. And they're also, one is relatively young, the other is only in his 50s. So.
Yeah, well, age is something that I know, Vikas, in your paper did matter, right? Age was a very big prognosticator in terms of the experience with COVID and prognostication with it.
Mm-hmm. It did, but even when you matched patients based on their age, meaning so people in their 40s, 50s, and 60s, those with cancer were still at higher risk than the ones without. When you look at
well, I think this is very interesting, especially with what Dr. Iwamoto just alluded to. And I know, John Bookvar and myself have discussed this a lot. In your study, it looked like patients who did poorly really were, they really experienced, they showed signs of this cytokine storm, this massive inflammatory response that has been associated with a poor prognosis. With the patients, with GBM patients, they're somewhat immunosuppressed, right, Dr. Iwamoto, to some degree. And so we've kind of talked about whether or not being able to mount the cytokine storm in a way can protect patients like glioblastoma patients. Although your study would suggest the opposite, as cancer patients who are on chemotherapy, didn't really do any better or worse than not.
Yeah, I mean, I think it's.
Yeah. Was there any data?
Dr. Iwamoto, what do you?
Go ahead, please. Yeah.
If there was any data on patients being on chronic steroids, for example, which is common in the brain tumor population, if that was either protective versus more prone to develop complications from COVID.
Yeah, it's a good question. I mean, I think, chemoactive treatment, meaning whether you were on current radiation or current chemotherapy, didn't pan out as being a particularly like a risk factor for patients. You have to take it with a grain of salt because we weren't exactly powered to sort of tease out all of the things. And I think some of that will remain to be seen. But I think to your point, I mean, it is kind of interesting. I mean, even within the hematologic malignancies, certain of them, like the myelodysplastic syndrome, and certain ones of them, you saw high, worse outcomes than others. So, there's something to the idea that, the immune system is playing, sort of is involved with this. And so that's kind of one of those things we were looking at as well. But, kind of one of the positive things was that you didn't really see people who were on active treatment, being at higher risk or succumbing to the disease, sort of kind of giving you some ammo to say, listen, we can continue your treatment as long as we do it safely, and that we shouldn't halt all cancer treatment.
Yeah, absolutely. Yeah. Well, I think that was a very key takeaway for me from your paper. And I think that's really, what motivated me to ask you on today. Because on one hand, your paper is saying that, all right, anyone, cancer patients, if you contract COVID, you have a higher risk of mortality. But then when you actually go through granular, information through the paper, it's like, well, actually, If you've got a lung cancer, you're at a higher risk, but other cancer types, you know, you're at a slightly lower risk. If you're on chemo and radiation, that doesn't really change it. It's really an older person with, you know, an aggressive cancer who's going to do worse. And in general, if you're showing signs of a severe COVID infection. So there, you know, there is a way to discriminate within there, or kind of triage how infected you are, rather than the initial assumption, which is, I have cancer, I'm terrified, I'm going to die of COVID if I get anywhere, you know? And I think this is important as we head into recovery now, where we need to find a way to tell people, no, you know, we got this. We understand how to take care of COVID now, and you're safe. You can come to the hospital, you can get your MRI, you can get treatment, you can see your doctor when you need to, right? We're going to do what we can to keep you safe. And so that's kind of where, that's, you know, I thought the interesting part about your paper, that's why I definitely wanted to have you on.
Yeah, I mean, I think you're totally hitting the nail on the head too, because I mean, I think the untold story, or the story that we're going to have to try to figure out is, you know, about all these patients who had their care delayed. You know, I mean, I think some tumors, it's not going to be a big deal, just like Dr. Iwamoto said. In some tumors, I mean, it's going to be a big difference. The fact that, you know, we didn't treat your tumor for 2 months, or people scared to come. And, you know, so far, I mean, I do head and neck surgical oncology. So, you know, I've been seeing more of the patients coming with more advanced tumors, things that I think they would have maybe come sooner if they had been less afraid. And so I totally...
Yeah, that's another thing we've definitely talked about. Dr. Iwamoto, do you feel that the patients you've had these telemedicine visits with, the interval follow-ups, do you feel like they've been becoming more, do they present to you more symptomatic? Have they been kind of hiding, letting their tumors grow or their disease get out of control?
Yeah, I think, you know, definitely I have a few cases, you know, anecdotally, yes, perhaps, you know, that a few were avoiding going to the ER and just, you know, let symptoms progress longer than one would expect during normal times. Yes.
Yeah. So the biggest issue for you guys, it seems like, has been really getting this chemotherapy at home when possible. That you guys have broken down some of the other barriers. It sounds like telemedicine's up and running. Are you guys having people back in your clinic yet or not yet?
Yeah, yes. In fact, we never stopped seeing patients live, just because we have many patients who need to just come for the infusions anyway, or on clinical trials that required, you know, IV or sub-Q or any administration of mental agents. So we're still continuing to see them, and we're expanding. We're seeing patients who, you know, are getting MRIs on the same day of the visit, and if they are just in the campus and they want to be seen in person, we can see them. Yes. Although we're trying to, you know, until this pandemic is really under control, potentially try to do as much as possible through telehealth.
Yeah, I think we've taken the same policy here. We've kind of revamped everything in a technology, you know, based, technology rooted kind of way forward. Vikas, are you guys operating again? Are you guys back up and running? Is there a delay?
Yeah, I mean, so pretty similar kind of stuff. I mean, I think we took a lot of measures once we noticed that people were, you know, contracting the disease and not doing well. So, you know, our cancer center, we did a lot of things to try and pull them out from COVID risky areas. And, you know, we've been pretty aggressive, Montefiore has, with testing, so, you know, in doing all the precautionary things that I'm sure is pretty universal across the New York City healthcare systems. In terms of, you know, and we've slowly started ramping up seeing patients. I mean, ENT, unfortunately, is one of those high-risk specialties where you're doing a lot of scoping and getting inside the mouth and this and that. And so we've had to be very careful about how we're bringing patients in and seeing them. You know, and procedures-wise, you know, I mean, we're staying pretty true to the governor's mandates. But for cancer things and things that are extremely urgent, life-threatening, we've started, we're back, and we've never stopped, but we're starting to open.
Yeah.
So.
Yeah, absolutely. Absolutely. So, I want to bring it back. I think there's something to this, the risk factors of patients with cancer. And Dr. Iwamoto, have you seen other patients with systemic cancer with metastases that have contracted COVID other than glioma patients? I know you said you only had 2 glioblastomas.
Yeah, I have not, but I do not do metastatic disease. So I don't. So
Yeah.
I don't see those patients. So if Mary Welch comes on, she sees a lot of these. Yeah.
Yeah, interesting. Yeah, we've been talking about it mainly in light of actually the reports of HIV patients, because it seems like there is a component of protection from lymphopenia in the HIV population. And listen, people still die of the disease. It's not 100% slam dunk that you're protected if you've got a component of lymphopenia. But I also know that, patients undergoing chemotherapy have lymphopenia in certain regards as well. So it's interesting to see the higher risk of mortality kind of confounded by, patients with depressed immune systems also living better or longer, surviving better. So it's all very interesting, very strange times. I hope that, we can all, maybe pool our resources and come up with answers too down the road. There's major, you guys are a comprehensive cancer center. Is Montefiore a comprehensive cancer center, Vikas?
Yeah, it is. It is.
Yeah. So, the resources are phenomenal between all these institutions, and, we should be able to, and we're fortunate in a way, although unfortunate, to be in the epicenter. We have all the information at our fingertips here. So hopefully we can all contribute.
Yeah. Lemonade out of lemons.
That's okay.
Yeah. That's right. Well, how do you guys see the future? What's recovery like? How do we send a positive message to patients and say, that things are going to get back to normal? We're still taking care of you.
So I think of this, and my chairman and I talk about this a lot. The side bent, the silver lining, I guess, or whatever you want to look at it here, is that this has allowed us a chance to hit the reset button in a way and take a look at, healthcare, the way that we operate, the way that the entire system operates, and, the way it works in the United States. I think there's a lot to think about. Some lessons that I think is, one, I think telemedicine is here to stay. Now that people have gotten a taste of, hey, look, I don't need to go see my doctor for these, silly kind of follow-up visits and stuff. I think people aren't going to want to go back to that, where they have to come in just for every little thing. And I think it will allow us to think a lot about, efficiencies and ways to improve the healthcare system. So, I think that's definitely going to be a huge part of making people feel safe, just allowing them to not have to come in unless they absolutely have to. And then, like everyone says out there, testing is going to be such a huge part of it. Not only testing patients pretty routinely, but I think the providers as well, and the people in the staff, having routine testing, I think is what's going to allow people to feel safe again. Those are the
absolutely
things that
you got to keep yourself safe when you're in the nose.
Yeah, that's right.
Right. Dr. Iwamoto, what about you? Are you obviously what's the biggest difficulty to a telemedicine visit, aside from a bad internet connection, which I've noticed that everyone seems to have?
Yeah, for me, I do think we miss a lot, because you miss a lot of the nonverbal communication, to be in a room with a patient in a family and deliver, news that are, no one can be ready to or expect to be able to be facing this, very difficult tumors that we deal with. I do think I think we missed that part. How their nonverbal communication is, and how what's the next sentence that will fit that the best. from a physician perspective, to have that human connection. I think we miss. I don't know what you guys think in surgeons like.
Well, yeah, I think it's a difficult thing because you're dealing with an intimate diagnosis, or you're dealing with this relationship you're developing with the patient as you kind of walk them through an extremely difficult part of their life, and to do it with a broken connection, or disjointed speak, or whatnot, dropped calls, it becomes very difficult. It's always better in person. Yeah, Vikas, how do you feel about it? What do you think?
No, I mean, big part of what I do is the physical exam, and not being able to actually look, feel, and see is huge. And I agree. Like, I mean, that human component of telling someone you have cancer and this is what we need to do, and not being, doing it over the phone, sometimes is definitely not ideal. Or not being able to put your hand on your shoulder or anything like that. I mean, it's hard for sure.
Well, I think for people listening, and we're going to wrap it up. I like to keep these to about 30 minutes, but I think for people listening, it's important to realize that just because you're doing a telemedicine visit doesn't mean you're not developing that relationship, and you can have that initial conversation. And I think you got to put trust in your doctor that if it's a situation that's important, or they're worried or concerned about you, they're going to bring you in, and they're going to do that face-to-face, or mass-to-mass meeting. And so I think, again, just always trying to keep positive and stay supportive for a patient population that was dealing with a lot before the pandemic hit. So I appreciate your guys' time. Thank you both so much for coming along. In the chat function, if you guys want to link anything or link to anything, it'll be promoted on the YouTube and through the people viewing at home. So thanks so much. And if you guys want to say any last words, or John, if you wanted to comment on anything.
No, thanks, guys. It was great. It's always good to get perspective from other organizations and other doctors and other disciplines. But it's fantastic. It's great to see everyone back to work and having benefited from this crisis in so many ways. So thank you, Andy.
Thank you.
No problem. All right. Take care, everyone. Stay safe.
Yeah, you too. Take care.
Thank you.
Bye-bye. Bye-bye.